And I know that's counter to what like most doctors ever say or recommend, but I've been doing this for nearly 3 decades, and I just can tell you that the other way does not work. That's just chasing something that is not going to work. This calorie counting and portion control and excluding food groups and questioning yourself of whether you should have or shouldn't have eaten this. That does not work. It's more questioning, did I fuel? Am I fueling adequately? Don't forget to fuel. Even if I'm not hungry, oh my gosh, it's been 4 hours since I ate. Probably should eat something. That's a different mental state.
This is Fat Science, a podcast dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better. This podcast is for informational purposes only and is not intended to replace professional medical advice.
I'm Dr. Emily Cooper. I've been treating patients with metabolic issues for over 25 years. I'm on a mission to raise awareness about metabolic dysfunction and why diets don't work.
Hi, I'm Andrea Taylor. I've been fat, very fat, chubby, morbidly obese, and done almost every diet ever invented. They all worked until they didn't. I've known Dr. Cooper forever, but when I became her patient and we learned metabolism was the real problem, wow, everything changed, and I've never been healthier.
And I'm Mark Wright. It's time for Fat Science.
Wait, does this podcast make me look fat?
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. It's great to see you two.
Hello.
Hi.
All right, on the show this week, we thought we would open the mailbag. This is an episode of Ask Dr. Cooper. I don't know, Dr. Cooper, every time I run into an expert at a cocktail party, I love to ask about their expertise. Could be a tax accountant, could be an investment advisor, could be an MD. Has your experience been that people bug you at parties and ask you for medical advice? Because if you and I were at a party together, I would. I'd say, Dr.
Yeah.
Cooper, this rash on my torso is just not clearing up.
I've definitely had that happen. I've had people say, can you come over here and check this thing on my back? Yeah, you get that quite a bit. Yep.
This is a socially acceptable way to ask Dr. Cooper. So the mailbag episode, and I just love the fact that people are engaging from all over the world. People are listening in Japan and Great Britain, South Africa. And gosh, hello to all of you from all over the world who are enjoying Fat Science with Dr. Emily Cooper. All right, this question comes from Kayla, Dr. Cooper. I just finished listening to an episode of Fat Science, really enjoyed your sensible approach and wealth of knowledge on GLP-1s. I'm on my 5th dose of Wegovy and things are not going great. The nausea, gas, really disruptive, making me want to go off it or switch to Zepbound. I'm starting by making my dose every 10 days to see if that helps. Anyway, I'm not asking for medical advice. I just wanted to inquire if you only work with people in person or if you do virtual appointments out of state. She's curious about that. She's in Vermont, where they don't have a lot of docs and expertise in this area of metabolic health. And she really feels like she's doing her own internet research on all this stuff. And in parentheses, she says, I know that's bad. Keep up the great work on Fat Science. Kayla, thank you for the question. So let's break down Kayla's question, Dr. Cooper. First, she's having some problems tolerating some of these GLP-1 drugs.
Yes, Kayla, thank you so much for the message. And the tolerance to the GLP-1 meds really varies individual to individual. But first thing is to talk to your provider to just make sure that you did start at the lowest dose. Most likely you did, because that's usually what's done. Although with some of the drug shortages that have been going on, some people are being started at higher doses than really the recommended. And so that could be part of the problem. But it does take a few weeks to acclimate to them for most people. But if it's been as long as you're describing, it does sound like you're having some adverse effects. And one of the problems with I believe you said it was Wegovy, one of the problems is it comes in a single dose pen. So it's not possible to reduce the dose because it's a fixed dose. And so you can't adjust it at all. And so if it's the lowest dose and you're using it properly and you're having those side effects, definitely need to, of course, contact your provider and discuss with them what strategies you'd want to do next, and whether it's something to do with maybe the starting dose being too strong, and how likely is it going to be that you'll acclimate over time if you're having this much trouble already. So I would definitely reach out to your provider to find out alternatives or to verify that the dose is the lowest dose that you can start on.
And we should refresh people, Dr. Cooper, these GLP-1s, they're a hormone produced in the gut that help, I guess, make you feel a little more full. But explain once again what the GLP-1s are and what are the most common side effects and why do those side effects appear so commonly?
They are mimicking a hormone from our gut that activates when we eat. And the side effects are often a slowing of the upper GI tract motility. And it's true that the tirzepatide has not as much impact as the semaglutide, which is what the Wegovy is. But most people can handle that. The exceptions would be if you already have some kind of a problem where your upper GI tract is not emptying at a normal pace. This can happen in people with diabetes and other causes of something called gastroparesis. So that's a situation where the stomach just empties much slower into the small intestine than normal. And so if you add on top of that situation medicine that's causing a slowing of the emptying, it can get to be too much in the way of side effects. And so I would find out if somebody's having a lot of side effects if they had baseline problems with their stomach emptying rates and a slowing of their stomach emptying that was causing an accentuation of the normal side effects. But normal side effects would occur in the first 6 weeks, and that's nausea, feeling overly full, and it can even be occasional vomiting. And that isn't that abnormal, actually, in the first few weeks at least. But usually the body acclimates, and by the time it's time to increase the dose, usually things are settled down. Although with the Wegovy dose escalation recommendations, it's very abrupt, much more so than what most doctors who are familiar with the medicine would advise. Going up slower on those dose escalations for most patients eliminates so many of those potential side effects. So that's something to look at. But the other little trick that we found for our patients is to definitely avoid drinking fluids at the same time as eating meals, because when you drink fluids, it activates these stretch receptors in the stomach. And that's the same effect that the GLP-1 has. And then it sends a really powerful signal to your brain that you may be overly full. And then you may not even be able to eat your meal, eat enough nutrients to keep nourished. And you may feel overly full, nauseated, or potentially slow your stomach emptying more. So separating out the fluids from the food can help a lot of patients. But the GLP-1, it works it's not really, the goal of it isn't just to reduce your appetite. That I don't like to call them appetite suppressants or even weight loss meds, because that may be an effect that they have, but the beneficial effects on the metabolism are so much more than that. It has much more to do with what's called energy partitioning in the body, how the body decides it wants to either store body fat or burn body fat, or how it affects our glucose levels and our insulin levels, which also impacts our metabolic rate and our metabolic function. So in fact, if you don't eat enough when you're taking these meds, it inhibits the action of the meds. In my clinical practice, that's what I have seen repeatedly. So you'd be very worried about extreme side effects at a low dose that might inhibit your nutritional intake, because then you're really not going to end up being able to sustain your nutrition levels while on that particular medicine.
Okay, I wanted to make sure we got to the part of her question, Dr. Cooper. Do you see out-of-state patients? How does it work in medicine? Because I did a telehealth thing recently when I had COVID, and they said, are you in the state of Washington? This is very important. Is it because you have to be licensed in every state if you're going to do a telehealth
That's
consultation?
right. It's really up to that state's regulations, but typically most states in the country do not allow doctors who are licensed in a different state to deliver care in that state. So we require patients to be in state for their appointments, even if they're telehealth.
Okay. And then the last part of Kayla's question, which I was going to ask you this anyway, because I've been struggling. When we try, we talked about supplements in the last episode, Dr. Cooper, and I think all of us want to feel like we can go do some decent research on the internet. But I struggle. I mean, even as a 35-year journalist, I struggle with knowing which sources to trust. So as we're going through our metabolic journey, Dr. Cooper, what's your best advice for how we should navigate the internet, navigate studies to know what we can believe?
It's so difficult, even when you really understand research and literature and you're used to looking things up medically and these medical publications. It's difficult because there are so many cases where things are retracted because they found that there was improper reporting on some of the results. And so that is definitely concerning. But for the most part, it should be published in a peer-reviewed journal. Peer-reviewed means that the findings are reviewed by a panel. And so what that panel is doing is looking for holes in the story and where there could be bias, researcher bias, or conflict of interest or something. And you do want to look at who funded the study and whether there are any conflict of interest disclosures. So, for example, in supplement studies, was it a supplement company that actually funded that study? Or because then it could be a bias study, but not necessarily. But it's good to keep that in mind. A lot of studies are funded by the pharmaceutical industry, but you just want to know who's funding that study. And then when you look at the headlines in the media headlines, then you look at the actual study behind it, it's often not the same. So they may be cherry picking something and using a fragment of something to present a misleading story that is that kind of clickbait type thing. So you have to go to the actual research and read. Often you can get access to what's called an abstract, which is a summary of the article at no cost. But sometimes to get the actual article, often you have to pay a very high price to get the actual article print PDF, and so that you can read the full thing. So if you're only able to see the abstract, what you want to look at is what kinds of people did they study? Was it people like me, or was it somebody completely unrelated to who I am? A different gender, a different age, a different makeup, ethnicity.
Was it 8 people?
Yes. Then the next thing is definitely the number of people studied and the duration of the study. How long was the study? Was it a 6-week intervention? Was it a 5-year intervention? Because it makes a difference. Because you can, as Andrea always says, you can force the body to do something in the short term, but that's everybody knows that with diets, but long term is a different story. So those are the things you want to look at. And then you can go to the methodology of how the study was conducted. What did they look at? And does that match what the headlines were? Often it doesn't. And then the conclusion, what was concluded. And often the conclusion will say, this needs further research. This was observed, but a normal peer-reviewed journal article, the authors actually list things that are flaws in their study at the end. They say that the areas of weakness of their study are X, Y, and Z, so that it's not possible to come to these definite conclusions without further research that eliminates those weak areas. So there's a lot to look at with those research studies. And just because someone has research doesn't mean it backs up what they're saying. So that's the other thing.
Yeah. And I think it's very much like trying to understand the world in journalism these days.
Yeah.
What I do is I tend to trust legitimate long-time outlets like the New York Times or the Wall Street Journal, or, in medicine, it would be the New England Journal of Medicine, Dr. Cooper, and what are some other publications?
Yes, they would be those more established publications. The JAMA, Journal of American Medical Association, New England Journal of Medicine, and Nature. Nature is a good one. Nature is a scientific publication that does some more intricate kinds of publications. But there are so many that are reliable, but I think it is good to avoid some of those fringe publications. There are so many fringe publications right now. I get in my inbox marketing from them, wanting me to publish something in those journals. And you can pay like $1,000 and have your article published. So anybody off the street could do that. And that is not the kind of journal that you want to see, look to for information. Textbooks are also very good. Specialized textbooks are excellent as well. And then sometimes looking at the references for articles, if you look through that reference list and you can link into where they got their supportive information in that research study, and you kind of follow that thread, you can find some very good information. But again, are you really going to be a full-time researcher?
Right.
Because it takes a lot of time.
Yeah. Well, Kayla from Vermont, thank you so much for listening to the podcast. And I hope Dr. Cooper's answers were sufficient. That's awesome. All right, Andrea, who's next?
I got one from Sarah. She says, "Hi, Dr. Cooper. I really enjoyed the latest podcast episode, Metabolic Meds. What again? Love the title too. The question I still have after the episode is this. Is weight loss on GLP-1 medications due to the correction of metabolic dysfunction regardless of calorie intake? Or is it due to calorie deficit, but the medication is reassuring the brain that it isn't a problem and preventing famine mode? I know that calories in, calories out is an oversimplification of a complex process. However, I can't help but wonder if part of why I plateaued is simply because I was eating just enough to bring me out of a deficit. It isn't that the medication isn't working, it definitely is, but maybe I'm accidentally having a bit more than needed to lose more fat. I'd love to understand it better. Thanks in advance."
I just love that question. It's a great question because it's illustrating how people who've been struggling with these problems for so long, how people think when they've been struggling so long with these problems. They think it must be something I'm doing. I must be eating just a little too much. I must be. And it isn't that at all. You wouldn't have to think about it so much. Think about people who don't have a metabolic problem. Do they think about how much they're eating? Not really. They just eat what they want to eat. They eat when they want to eat, they eat what they want to eat, and then they forget about it. Well, yeah, it's not that they're thinking, oh, maybe I had, too many of, these berries or something, or I had too much peanut butter, or I had too many cookies or something.
Or I ate the crust.
Or I ate the crust. Yes, exactly. And so the medications do help reverse the famine signals in the brain because they are producing a positive input signal that's very reassuring, that says we have enough food supply. And it's a neuroendocrine signal. So it's informing the brain that there's adequate food supply. And based on that, your brain will reduce the level of famine signals that it's pumping out, basically. But if you go on a calorie deficient diet while you're on that medicine, it will confuse the brain because it's getting this signal, we have enough fuel supply, and then it's looking at the nutrient levels because it doesn't just look at only that signal. It wants proof. It's looking for your nutrients coming in, and it sees there's a deficit. And so it says, uh-oh, wait a minute. I don't know if I should believe this. I'm not going to lower those famine signals. So maybe, Sarah, maybe you're not eating enough if you thought about it. Maybe it's the other way around. So it's hard to say. It's not the food is what I'm trying to get at. The purpose of the food and the fueling is to provide a secure nutrition base that is proving that you're not going into a deficit and that you're not starving yourself. And if that were good enough by itself to reverse the metabolic dysfunction and the famine signal imbalances, that would be great, but it just isn't. And that's why we use the medication to help boost that signal that we're not in a famine, that we have enough food. But you have to use those two things together. And I know that's counter to what like most doctors ever say or recommend, but I've been doing this for nearly 3 decades. And I just can tell you that the other way does not work. That's just chasing something that is not going to work. This calorie counting and portion control and excluding food groups and questioning yourself of whether you should have or shouldn't have eaten this, that does not work. It's more questioning, did I fuel? Am I fueling adequately? Don't forget to fuel. Even if I'm not hungry, oh my gosh, it's been 4 hours since I ate. Probably should eat something. That's a different mental state.
And it's hard to change your mindset to do that because, especially with the GLP-1 drugs, you're not necessarily feeling the hunger like you used to feel the hunger. So you do have to think about it a little bit, but you do have to eat. Otherwise, you're going to probably feel your body is going to feel a little famine-y.
Yeah. And gosh, Andrea, just this morning, I woke up and I just did not feel hungry and I had to force myself to have breakfast. And, because I know the dangers, I probably could have gone to 2 or 3 in the afternoon without eating and felt okay. But just, knowing the advice that Dr. Cooper has given us, that systematic eating is just the best thing to fuel our bodies.
I think that's why I wake up and I always put protein drink in my coffee first thing in the morning so that I start my day instantly with some sort of fuel instantly because I don't feel like eating necessarily right away. So I call that breakfast number 1. And then like 2 hours later, I feel like real breakfast and I have food. But I at least have had some sort of nutrition right away.
And then, of course, the doctor and me will tell you, well, you have to have something else with that because it's not
come
enough.
On, Andrea.
Right. And 2 hours is too long.
Right. But at least I've had the protein drink that has a lot of stuff in it.
Where's the carbs? Where's the fat?
Well, it does have stuff in it.
Oh, it has carbs in it? Okay.
Yeah. It has everything in it.
Oh, good.
The
Excellent.
protein drink has everything in it.
Oh, okay. Then we're good.
Right. And then I have another breakfast.
Yes. Good. Then we're okay.
No, the awesome. Protein drink has all the stuff in it. And then I have another real breakfast like 2 hours later.
Okay.
That's good.
Well, Sarah, thank you so much for the question. Here's an interesting question now from KM Spinks. In reference to the metabolic struggles of an Iron Woman episode, I thought that was such a fantastic episode. So KM Spinks asks, Dr. Cooper, this episode was a light bulb moment for me as I was recently in this exact position, training harder on increasingly fewer calories and gaining weight. Now on MJ, I'm guessing that's Manjaro, I have lost the weight, but I'm only eating about 800 calories a day. I don't know how to reverse out of this situation and start eating/training again without a huge rebound gain. What should people like me do to reset the system, please? So KM Spinks, thank you so much for that question. So Dr. Cooper, this is a really interesting situation. If they start training again and they're only eating 800 calories a day, you have to think that the metabolic system is going to rebel, right?
That's right. Yes, it's a really touchy situation. The Mounjaro is temporarily protecting against those biologic weight defenses, but that doesn't last forever. And the point is, no one should go back to exercise or even just daily living without eating more calories. And so what the best thing to do is to probably hook up with a dietitian, a registered dietitian who is not a dietitian or anything, maybe somebody with some eating disorders background. Not that I'm saying that there's an eating disorder here, but I'm just saying some of the dietitians who specialize in eating disorders such as anorexia, they actually end up having additional skills that are helpful for people in this situation where there's so much mentality attached to eating that little and the history of exercise that they could really help illustrate what normal eating looks like and to make sure that you're not in this deficit any longer. So the first thing would be that the dietitian would help guide normal eating for daily nutrition without putting the exercise back and getting those calories up to a normal level, whether it's, I don't know what it is because I don't know anything about the person's metabolic needs, but it would be somewhere around anywhere from maybe 1,700 calories a day to 2,300 calories a day. If this is a female, and if it's a male, it would be even higher. But the dietitian needs to get that established first, eating at that level and continuously for a while. And then typically we look at things medically, like hormone levels and nutrition levels, to see if those are adequate, and only then start introducing exercise. And that exercise should be accompanied by additional fueling. So the dietitian can help with that too and say, okay, how much are you going to be exercising? Then you need to add this snack and that snack. And if it gets to be more, you need to add a sports drink and you need to add. So someone with either sports nutrition background or eating disorder background to help, but a registered dietitian who has that extra medical training would be a good person to start with to help dismantle from that diet mentality and the diet history.
All right. Thank you so much for the question.
Okay. Next up on our hit parade is from Alex. I'm really enjoying your podcast. I would love it if you could talk about those of us who have no underlying health issues. We're just overweight. What's the alternative to dieting?
Great question.
That's a good one. Well, first of all, you'd have to look clearly at your health and metabolic profile, because sometimes there can be something there that might be missed. So you just want to make sure you've had a thorough look at the metabolic system, because not everyone has metabolic syndrome, which is that higher risk health-wise condition where we have cholesterol imbalance, we have fatty liver, prediabetes, hypertension. So if you're not in that category, the question is, well, is there any clue as to why the weight is as elevated as it is? What does the blood work say about that? Are there imbalances in any of those metabolic hormones? Is there any imbalance in your blood sugar and insulin response, either fasting or after eating? And can you get any more insight as to what is the cause of that? So that's what I would say first, because it's always good to see if there is any kind of underlying cause that can be identified. But then if truly a person is really healthy and just their weight's elevated and they don't mind having the extra weight, then they don't have to do anything to lower the weight. But often metabolic dysfunction comes with like fatigue, because the metabolism is what gives us energy. And if there is a slowing of the metabolic function or disruption in the metabolism, that often can lead to elevated weight. There can be fatigue with it too. Or there can also be mobility issues if the weight is very high, where it's difficult to get around. So you kind of want to look at, is there a reason that I don't want to be at this excess weight, or am I comfortable at this weight and I know I'm healthy and I have plenty of energy? So that's where the person really kind of has to decide what's right for them. But if a patient came to me and they're saying, I don't want this excess weight because of, I am tired, I want to look at my metabolism more detailed because I do have these other symptoms of being tired or mobility issues, or I just don't want this excess weight, then we do a thorough metabolic lookup in the lab work mostly to try to see if we can identify why that excess weight is there. And then more of a targeted treatment to tackle that issue. And so that could be different things for different people. And again, it never will be a diet, so to speak. It never will be a calorie restrictive diet or exercise that's not fueled, because all that does is put more weight on in the long term. It's just going to exacerbate the problem. And it may even create a secondary metabolic problem on top of whatever the original issue was. So does that mean you can't make your diet higher quality or work on your sleep or rule out sleep apnea? Of course, all those things could be done. Get into an exercise program, all that can be done. But those we know from research are not likely to reverse an abnormal body weight elevation. So that's where it's still, okay to consider a pharmacologic approach in that situation if that's something that a person wants to do. And it's also okay not to take a medical or pharmacologic approach if a person is comfortable in their body and doesn't have a health concern and is having a good quality of life. And of course, there's no need. We don't want to feed into the weight stigma of our society. So it's a hard balance, because there are various groups that are very anti weight loss, and there's the health at every size movement, which of course we can be healthy at any size. We've proven that you can be healthy or unhealthy at any weight. And so weight does not equate to health. And so we're big believers in that, but also believe that a person's choice can be that if there is abnormal weight gain or abnormal weight accumulation from something, and sometimes it's like a medication someone took a long time ago, or it's something in their genetics, or it's something like an old diet that they went on that messed up their metabolism, then they have every right to pursue something to balance their weight proportion. That could be a medical approach. But again, it's a very personal decision, and I never recommend diets. But if say this person was not eating regularly, was staying up late at night, of course, those are areas where you could start focusing. Get enough sleep, 7.5+ hours, start eating whole foods regularly throughout the day to reassure your body that you're nourished, avoid the chemical additives and the endocrine disruptors, turn off your electronics at night so that the ghrelin levels don't go up. So there's a lot of lifestyle little things that you can do, but it focuses a lot more on consistent fueling and not any kind of calorie reduction or magic supplement that promises all these things.
All right. Alex, thanks so much for the question. We have one more sort of short one. This is from Kate. Not necessarily a question, but it plays off what you just said, Dr. Cooper. Kate says, I like learning, so this is really good. Glad you're enjoying the podcast, Kate. She says, I am thin, but have high cholesterol. I'm mostly vegetarian and transitioning to a more vegan diet. And this plays into just exactly what you were saying, Dr. Cooper. Body shape, body size, a lot of times doesn't have a correlation to good health. Kate's thin, but she has high cholesterol, which can be really threatening, right?
Yes, it can. And so what we want to look at is we had a previous podcast about heart health and metabolism. So I would listen to that, Kate, to make sure that you've had a thorough look at your LDL particle counts, lipoprotein A, depending on your age, maybe a heart scan, just to assess your overall risk. But even though your weight is not elevated, you should also rule out the possibility that you might have metabolic syndrome too, because about 25% of normal weight people have metabolic syndrome. And so that's a large number. And metabolic syndrome is a mixture of cholesterol problems, elevated blood pressure, insulin regulation issues, or prediabetes. So a lot of times people at a normal weight are kind of neglected a little bit because they're told, well, you must be fine because your weight's normal. And just the same as people with a high weight are told, well, your cold is because of your high weight. So either way, things are often missed. So I would just make sure that you do a thorough check and see how far does this go? Is it just an isolated cholesterol problem, or is this a metabolic dysfunction in your case too? That is just you're not susceptible to the elevated weight aspect, but you may be susceptible to the others. A lot of that is genetically determined. And so it may be that you don't have the genetics for the high weight, but you may have genetics for something else. So I would definitely get a more thorough check rather than just the cholesterol. Look at the LDL particle counts, lipoprotein A, and the apolipoprotein B. And if everything, it may be that you actually are okay, because it may turn out that you don't have the bad LDL elevation and that you don't have the LDL particle elevations. So you actually might not be high risk. But if you are, make sure it's not also connected to other aspects that could be metabolic syndrome. And if so, that should also be treated regardless of the fact that you don't have the high body weight.
This has been so much fun, the mailbag edition of Fat Science. I look forward to future mailbag editions. I learned a ton. this time. Dr. Cooper, if people have questions for you, where can they send them?
Send me an email at info@diabesityiinstitute.org. That's info@diabesityiinstitute.org.
All right. Thanks for listening, everyone. This has been another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.
I'm Mark Wright. Thanks for listening to Fat Science with Dr. Emily Cooper, a Work P2P production. New episodes drop every Monday. If you've enjoyed the conversation, subscribe, rate, and review this podcast. This production is for informational purposes only and is not intended to replace professional medical advice. Join us next week for another episode dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better.